Hi, everyone. My name is Amanda Zongrone. I'm an Associate Research Fellow at the International Food Policy Research Institute. And today I'll be presenting on our findings and experiences in assessing the feasibility of an integrated nutrition program in peri-urban and urban Senegal. To begin, I'd like to give you a brief background of nutrition in Senegal. Senegal has a national community-based management of acute malnutrition, or CMAM protocol. And this protocol was updated in 2013, and the update highlighted the need for a community-based approach to targeting acute malnutrition, which integrates screening, referral, and outpatient treatment at the community level. Senegal has nutrition surveillance at the community level that has been ongoing since 2009, and this has been implemented through the CLM. And the CLM is a unique body in Senegal. It's a coordinating body for nutrition that is housed in the Prime Minister's office. It's a centralized political and administration hub that coordinates nutrition across all sectors. And the CLM implemented this program through the PRN. The PRN is primarily focused in rural areas and does not have a specific protocol for urban areas, however. Within the PRN, they do state that communities that don't have a health post can set up their own nutrition, education, and rehabilitation sites within the community where they can perform behavior change communication, growth monitoring, and the management of moderate acute malnutrition. Severe acute malnutrition would be managed at the health center level. So while the prevalence of MAM and SAM, moderate acute malnutrition and severe acute malnutrition, are relatively lower in urban areas compared to rural areas in Senegal, the caseload is high for acute malnutrition due to population density. You could see here with the statistics for child under 5 weight for height. In Dakar, the capital city in an urban area, we see 3.1% of global acute malnutrition, and in rural areas, we see 6.8%. So you can see it's a little bit lower in urban areas. However, due to the high population density, there still is a relatively high caseload. So peri-urban and urban children do have the potential to benefit from a preventive community-based management of acute malnutrition program or services that have been integrated with regular screening, case detection, and referral. And bringing an incentive to screening might increase participation in screening. And this leads me to describe the intervention called Promis, which was funded by Global Affairs Canada and implemented by Helen Keller International. So the intervention and evaluation was motivated by the lack of evidence on both the effectiveness of an integrated approach to malnutrition and how to successfully integrate the preventive services for acute malnutrition into the CMAM model, which is largely focused on treatment. So the Promis theory of change, and Promis is an acronym for Innovative Approaches for the Prevention and Treatment of Child Malnutrition. The Promis theory of change is built upon the existing platform and procedures that are outlined in the National Protocol for Improving Child Nutritional Status. So at the community level, in the existing platform, there's monthly screening of mother-child dyads, which lead to the referral of globally acutely malnourished children. And then at the health facility level, treatment for those children leading to better child nutritional status. And this is all outlined in the National Protocol. The Promis program implemented an integrated intervention package that provided behavior change communication on infant and young child feeding practices, essential nutrition actions, and essential hygiene actions to caregivers, and a preventive dose of small quantity lipid-based nutrient supplements for mothers who attended screening and had children 6 to 23 months of age. So this integrated package was designed to be delivered at the monthly screenings. And in Senegal, at the time when these services and products were received, is referred to as the Promis session. And I'll use Promis session throughout the presentation. So the Promis session consisted of this monthly screening with behavior change communication and the provision of a monthly supply of SQLNS. So the integrated package was intended to increase attendance at the screening, leading to more referral of globally acute malnourished children, more treatment of GAM children, and the lower prevalence of GAM. And the additional add-ons were intended to increase infant and young child feeding practices, leading to more prevention of acute malnutrition, and therefore better child nutritional status. This intervention was also conducted in Mali and Burkina Faso, in addition to Senegal, but today I will only be presenting on the results of the feasibility study in Senegal. So in collaboration with program implementers, we detailed a program impact pathway that describes how the program theory of change will be implemented and executed in Senegal. And so here I'll present a simplified program impact pathway for Senegal. So beginning with training and community support, HKI implemented cascade training for negotiation techniques, which is negotiating with caregivers on how to change behavior successfully. The community-based management of acute malnutrition and SQLNS guidelines. And this was given to all HKI staff, staff from the Ministries of Health, local NGO staff who helped HKI in implementing the program, health workers, and relays, which are health volunteers. They received support from the chief of the village prior to implementing the program, and then this led to installation of nutrition sites in convenient locations that were supported by the chief of the village. The cascade training led to HKI and local NGO staff giving formative supervision to the relays. And the supervisors would check monthly at the household level if all eligible children were receiving the program. Relays received monetary incentives, which motivated them to request SQLNS from the poste de santé, which is the health post, and transport the SQLNS to the sites. They also conducted a census of all eligible children in the area that they were supervising. And the NGO supervisor would then enter the census data using a phone into a database so that they had a record of all eligible children in the area. The heart of the program here in purple is relays would gather mothers in groups by child age at the nutrition sites and verify attendance with the census data. The relays would give behavior change communication, screening for acute malnutrition, and distribute SQLNS to mothers of children that did not have a MAM or SAM. Absent mothers would receive a home visit from the relays and support group members. So the main delivery of the program was at these nutrition sites, and then there was a follow-up of anyone who didn't attend based on the eligibility from the census data. And the idea was this would improve the coverage of screening, and mothers would receive SQLNS for the child and would bring back the empty packets at the next visit, and were therefore incentivized to return to the sites to receive the SQLNS and the behavior change communication, therefore feeding back to improving the coverage of screening for acute malnutrition. Not part of the program, but a follow-on to screening was referral and treatment. So any SAM child, severely acutely malnourished child that was identified, was then referred to the health center. The health workers would give SAM children treatment, and then they would be followed up at the health center. Unfortunately, currently in Senegal, there is no product for the treatment of MAM, so those children were not referred. So specifically in Senegal, the program was adapted for the peri-urban and urban context. In the peri-urban context was Pout, a region called Pout, and the urban context was called Guédiawaye. And how Promis Senegal was adapted for the peri-urban and urban context was that women's time and monetary constraints were taken into account. Women more frequently had work outside of the home and many other activities and programs that competed for their time. So the program took this into account when designing the intervention. And they did this by holding the sessions in the evening, locating the sessions conveniently to home, and therefore decreasing transportation time and transportation cost. And they utilized home visits and follow-up phone calls from mothers that did not show to the session. There were also some competing priorities for the relays that the program took into account when designing the program. They provided the monetary payments to relays because they had many other activities that they were being asked to do, and they wanted to motivate them to complete their Promise activities. And they received 15,000 SEFA per month for conducting Promise activities and 2,000 SEFA of phone credit. And based on the average monthly salaries in this area, this is more of an honorarium and not a salary. So to give a little bit of the context of where the implementation of the study took place, you can see here in the red box, I have highlighted Dakar, Senegal, which is the capital city. And expanded out, you can see that Guédiawaye, the urban context, is right on the outskirts of the city, and Pout is just outside of the city, the peri-urban context. So the objective of our study was to assess if it was possible and appropriate to implement the program as designed in peri-urban and urban Senegal. And we use the term feasibility here, but I just want to emphasize that we looked at feasibility as the program was ongoing. So the feasibility of implementing the program as designed as the program was ongoing, not in advance of implementing the program. We used a framework for assessing feasibility, which contains 7 key areas of focus. And these were adapted from Bowen et al. 2009. And these 7 key areas of focus included acceptability, demand, implementation, practicality, adaptation, integration, and potential for impact. We designed our research questions around these areas of focus. So for acceptability, we looked at to what extent the program was judged as suitable, satisfying, or attractive to program deliverers and program recipients. For demand, we investigated to what extent the program was likely to be used. For implementation, we asked, to what extent can the program be successfully delivered to intended participants? For practicality, to what extent can the program be carried out with the intended participants using the existing community and health center structures? Adaptation, to what extent is the program adapted to the peri-urban and urban sites in Senegal? Integration, to what extent is the program integrated within the existing health system? And for potential for impact, we looked at, does the program give an indication of potential success with the intended population? And we've organized the results around these research questions. And we asked all of these research questions along the program impact pathway. So the idea is that if the program impact pathway is followed well, then the program theory of change should be carried out. So before I present the methods we use in this study, I want to place this feasibility study within the Society for Implementation Science in Nutrition's classification scheme for implementation research. So this is a nutrition-sensitive, integrated preventive program that is linked to CMAM detection and control and fits within nutrition-sensitive actions. So I've highlighted planning and design within nutrition-sensitive actions and implementation, iterative improvement, and scale up here. And this is where I believe that this study falls. As the feasibility study documented the design of the program by working closely with implementers to develop the program impact pathway and conducted the feasibility study to understand if it was possible and appropriate to implement the program as designed in the peri-urban and urban context in Senegal. I therefore put it under planning and design. So in doing that, we documented the unique successes and challenges of implementing this program as it was designed for this context and provided feedback to the program for iterative improvement. So to answer the feasibility research questions, we use the program impact pathway approach, which was used as both an analytic tool and to design data collection instruments. We use a combination of random and propositive sampling. We randomly selected 10 community nutrition sites in each of the 2 locations as the basis of our sampling frame. Here I present an overview of the sampling that we used for the feasibility study. We used semi-structured qualitative interviews and group free listing. For the interviews, we interviewed mothers, community volunteers, warehouse managers or depositaires, NGO assistants, and NGO supervisors. We interviewed mothers of children 8 to 23 months of age, and we proposively selected 2 per randomly selected site, for a total of 40 mothers, and 20 in the urban area and 20 in the peri-urban area. We interviewed all of the relays that were implicated in Promis in the randomly selected site, but we limited it to 2 relays per randomly selected site. In rare cases, there were 3 relays that were implicated in Promis at the site, and in that case, we randomly selected 2 to interview. And this was for a total of 37 interviews with relays. We interviewed all warehouse managers, and they were mainly in charge of the SQLNS, and we interviewed all of them that were implicated in the program, all of the NGO assistants and NGO supervisors that were involved in implementation of Promis. So we also use group free listing, which is a technique that's used to generate data that describes how discrete domains with listable content are categorized by a group of people. So we ask a group of people to list out items in a discrete domain, and the order in which the item falls on the list and the number of times the item appears across multiple lists can represent the saliency of the item. So more salient words are assumed to appear more frequently across respondents or appear at the beginning of a list. So we conducted group free listing with mothers of children 6 to 8 months of age and 9 to 23 months of age who had recently participated in the Promis session. We conducted 2 group free listing at each Promis fixed nutrition site. And this was an opportunistic group of women, and so we had anywhere between 5 and 15 mothers per group. All of the qualitative interviews were audio recorded, and then later when we came back from the field, they were simultaneously transcribed and translated from Wolof into French. The group free listing was transcribed and translated on paper right there as the enumerator collected the data, and a backup audio recording was used to verify transcripts later when we were back from the field. So we explored several themes in each data collection method. For mothers' interviews, we looked at program experiences, the quality of the services they experienced, and generally their experience with the program, including barriers and facilitators to participating in the program, the acceptability of different aspects of the program, and what were their perceived incentive structures and costs were to receiving the program. For community volunteers, we looked more at implementation, structure, and management, and their motivation to carry out the program as designed. We also asked them about barriers and facilitators of program implementation and how the program was integrated into the existing health system. The warehouse manager was asked about their distribution procedures and any barriers and facilitators to them carrying out their job as needed, and we asked them about all of the steps along the supply chain for management of the SQLNS. For the NGO assistants and NGO supervisors, we asked them higher level implementation questions. We asked them about the theory of change and their perceived general program strengths and weaknesses, and what they perceived to be barriers and facilitators for implementation for the volunteers and for mothers taking up the program. In addition, we asked them how they perceive the program was implemented into the existing health system. For group free listing, we generated 2 groups of lists, one on salient behavior change communication messages that were recalled by mothers, and the other on the use of SQLNS. We used thematic analysis for the interviews, and an a priori code list was developed, but this code list was left open to emerging themes, and we used 2 standardized coders to code the interview data. For free listing, the frequency of the responses were coded and using a list of themes that were developed by HKI for the Promis BCC sessions in advance. And so we coded all of the data that came out of the BCC free listing based on these predefined themes. For SQLNS use, we coded them using the themes that emerged from the data without any pre-existing list. And these were analyzed using Stata. So moving along the 7 key areas of focus, I'll present the results now. For acceptability, overall, we found that Promis was perceived as acceptable by beneficiaries and volunteers. Program deliverers noted that mothers were welcoming and Promis was well integrated in the community. They identified transportation of SQLNS as a key barrier to program acceptability for them, but this was resolved very early on in the program after HKI provided them with a car to ease the burden of carrying the large quantities of SQLNS that were needed for each session. One important thing that came out of acceptability was mothers reported very positive relationships with the volunteers and perceptions of the volunteers. Mothers said that they were friendly, meticulous, hardworking, gave important advice, and encouraged them to attend sessions. So this is a particularly important finding for an integrated CMAM program, as we know from other studies in other contexts that stigma and shame around screening for acute malnutrition can cause women to not attend sessions for screening. Mothers identified SQLNS to be the most attractive component of the program, and then later followed by screening and much later behavior change communication. They gave us feedback that they would have liked more information on the use of SQLNS and more information about the results of the screening that was performed on their child, where their child fell in terms of acute malnutrition. They also said that they felt BCC was too limited. They wanted more interaction and more of a dynamic dialogue for behavior change communication. They also requested that medical diagnoses would be added to Promis services to make the program more attractive. And one theme that came out consistently was that they wanted more at the sessions. They wanted everything all in one place. So when we looked at demand, to what extent the program was likely to be used, we found that the demand for program services was increased by the proximity of the sites to mothers' homes and the effective communication about the schedule of the sessions. Mothers did say that SQLNS added value to them for the program and motivated them to attend the sessions. However, one strong theme that came through the interview data was that SQLNS was not enough of a motivation for them to attend the Promis sessions regularly. It was somewhat of a motivation and somewhat of an incentive, but not enough to attend very regularly. They talked about time constraints that they faced and other activities that they had to prioritize over attending the Promis session, and these included household tasks or other paid work. They also stated that they lacked interest in the BCC topics. And again, this gets back to the more of a dynamic BCC session. The mothers reported that they really wanted to see a more dynamic BCC session. They also, in some cases, said that their child didn't like the SQLNS, so that they didn't have motivation to attend the session because they didn't need to receive the SQLNS. A salient theme that came from volunteers as well was that it was difficult to get participants to come to the sessions or show interest in the sessions. So this really lines up with what the mothers were saying. I have a quote here to demonstrate this. One volunteer said, "The women don't come to take the SQLNS. They refuse to come. You have to bring the SQLNS to their homes, do the home visits and individual interviews, discuss with them in their houses. You can go to a house and find 5 women and take the SQLNS. You can call them and group them together to discuss with them." Let me remind you again of the program impact pathway, and the idea of the program was that it would be delivered at the Promis sessions and that the home visit would be only a follow-up for mothers that did not attend. And I'll come back to that again a little later on. For implementation, we found that volunteers generally understood how the program was intended to be implemented, and they attempted to implement the program as designed. You can see here a picture of a Promis volunteer giving some information while holding up the SQLNS packets. It's after the BCC that I start doing the work of the SQLNS distribution. I start by screening the children. If the child is healthy, I encourage the mother and congratulate her. If the child is in the yellow, this volunteer is referring to the MUAC tape, I make a referral and make an appointment with the mother to bring the child to the health post for care. So this volunteer is describing well the process by which the program should be carried out. We did find that some volunteers who were interviewed had a limited understanding of the program. One example is they would describe using screening only to determine SQLNS eligibility and not for acute malnutrition. So faced with the low demand for the program by mothers, the volunteers modified the program in an effort to reach all eligible beneficiary mothers. So this resulted in a heavy reliance on home visits as opposed to the Promis session. And these home visits not always including screening or behavior change communication, but rather distribution of SQLNS. Additionally, we heard that at each session, each component of the program was not always provided. SQLNS was delivered consistently, however. And so there was this general focus on distributing SQLNS. And one question that we have is, could this be due to the monetary incentive being linked to SQLNS distribution? One volunteer said, "For me, the biggest barrier to implementation is the non-frequentation of the beneficiaries. If they came to the site, it would really help us with the tasks. Because if they came to the sites, we could do our Promis activities on 2 days. Then we could do other activities. But in 10 days, we only have 100 beneficiaries, while we should have 500. This is what makes it that we work until the 20th of each month." So the Promis program, the volunteers start their activities at the beginning of each month. So instead of this volunteer finishing in the first 2 days of the month, she's not finishing until the 20th of the month. Overall, from our assessment, we found that the practicality of the program as designed is low. First, I want to look at the practicality of the platform, the community nutrition site. And clearly, we can see that the attendance problems coupled with the volunteer monetary incentive led to a reliance on home visits. The volunteers, in an effort to reach more beneficiaries with SQLNS, they conducted the home visits or dropped the requirement of screening and BCC, limiting the practicality of the community nutrition site as a platform. When we look at the practicality of the integrated program, we find that, again, these attendance problems at the nutrition site, coupled with the volunteer monetary incentive, decreases the integration and breaks down the program theory of change. The volunteers had to spend a lot of time and effort to deliver the program to beneficiaries on these home visits, which often led to dropping the requirement of screening and BCC, which are components of this integrated package. When we examined to what extent the program was adapted to the peri-urban and urban sites, we found that there were a couple components that were very adequately adapted, that Promis adequately adapted to, and these included transportation constraints for beneficiaries in the urban site. In the urban site, the mothers talked about the convenient location of the sites and that they didn't have to pay for transportation, and the communication requirements of beneficiaries. In both sites, the beneficiaries talked about how the communication was well executed, and they knew when the session was going to be held, and they knew when, and they had good communication about follow-up. However, Promis's design was inadequately adapted to the time constraints faced by mothers. It was not enough of a motivation for them to attend the session based on their time constraints. So maybe if this program could somehow work outside of their time constraints, they could have attended more easily. And additionally, there was a lot of competition with other nutrition-related interventions in the urban site, and this also relates to time constraints. In the peri-urban site, mothers did discuss transportation constraints and that they had to pay for transportation to attend the nutrition site. Integration was a clear strength of the program. The nutrition sites were affiliated with a health center, and the integration was ensured through referral of children with acute malnutrition, volunteer supervision, and SQLNS management. So in the integration question, we're really asking about how well the program is integrated within the existing health system. And the program collaborated well with the health staff. The health staff, for example, selected, trained, and monitored volunteers. They also used existing infrastructure to order, deliver, and store the SQLNS, not recreating the wheel. The warehouse managers were usually already working to manage health products at the health centers and easily manage the SQLNS distribution. And they integrated this into their stock management or regular stock management activities. We use the free listing results to feed the limited advocacy area of focus and give an idea of the demand side of the intervention. I want to note that we did not, however, measure coverage estimates or other aspects of the demand side to inform the assessment for potential for impact. So when looking at knowledge, we found that mothers' recollection of behavior change communication messages revealed that child feeding and hygiene were the most salient messages they recalled. We also mapped these messages to existing scientific recommendations. We found that 75% of what the mothers spontaneously recalled during the free listing sessions was consistent with recommendations. When looking at the use of SQLNS, 64% of the free listing responses indicated that only the beneficiary child consumed the SQLNS, which was the recommendation. Mothers were the next commonly mentioned person to consume SQLNS, not surprisingly. 55% of the free listing responses noted that SQLNS was consumed alone, and 40% mentioned that it was mixed with other foods. So you can see a mixed usage of the SQLNS in modality of feeding to the child. So in the discussion, coming back to the feasibility study objective, the objective was to assess if it was possible and appropriate to implement the program as designed in a peri-urban and urban context in Senegal while the program was ongoing. So overall, we found constraints to the feasibility of implementing the program as designed. Our conclusion is that the program requires a redesign to better address constraints to participation in this context. And additionally, a redesign on the volunteer incentive structure so that the incentive structure follows the program theory of change more carefully is something that we recommend. However, the integration of the program into the existing health system was a clear strength. The volunteers responded to program challenges. However, the program modifications they made to the program impact pathway that were made by these volunteers to reach beneficiaries were not in line with the program theory of change. And it clearly showed that the program delivery platform requires further thought and adaptation to this setting. When the volunteers provided SQLNS without the conditionality of both screening and BCC, this indicated a lack of understanding of the program impact pathway and the program theory of change among volunteers. So the idea would be either to get all of the volunteers on board with the program impact pathway and the program theory of change, and then they can make modifications as necessary, or to adapt the program more clearly to the specific needs of the setting so that these modifications would not be necessary. Otherwise, this limits the potential success of this kind of program. So coming back to the classification scheme for implementation research, I want to restate a point that Dr. Pelletier made after this classification scheme was presented at a recent conference. So paraphrasing what he said that the design of the evaluation should be appropriate for the decision and for the context. We don't always need an impact evaluation for every study, and that we need flexibility in methods. I think that the result of this study demonstrated that it was important to do a smaller, less expensive study like a feasibility study first, so that the design of the program could undergo some changes before implementing at a larger scale or in a similar context. So with that, there's many people to acknowledge, including colleagues at IFPRI, our funders, Global Affairs Canada, our implementing partners, Helen Keller International, and the staff and volunteers of the Health District in Guédiawaye and Pout, and the communities of Guédiawaye and Pout.